All right, so the ECHO model is collaborative, and we ask that when we are in small groups, please leave your webcam and microphone on. Our breakout groups will be the time for discussion, and any time that you need to ask a question, please use the chat. We will have someone monitoring the chat to answer any of your questions. And lastly, renaming your profile. You can do this by clicking on the 3 dots on your picture, and then you just click rename. Please just change that to your full name and where you work, and your title if you'd like. All right, and now I will introduce my colleague who is going to be our facilitator for today, Rebecca Dosh-Brown, and she works as the Institute on Community Integration's Interdisciplinary Education Director. Her job is to help run the Minnesota Leadership Education in Neurodevelopmental and Related Disabilities, or MNLEND, Fellowship Program, and the Disability Policy and Services Graduate Certificate Program. And she also builds new interdisciplinary university and community partnerships. Welcome, Rebecca.
Okay, thank you, Courtney, for your welcome, and welcome to Project Scope, everyone. It's nice to have you here today with us. Allow me to provide a brief introduction to Project Scope, just in case we have new guests with us today for session 2. Project Scope stands for Supporting Children of the Opioid Epidemic, and our goal is to build a community of learners to share knowledge on better supporting families who have children who were born with Neonatal Abstinence Syndrome, or NAS, or Neonatal Opioid Withdrawal Syndrome, or NOWS. While we developed this series of trainings to specifically build community among Minnesotans who are early childhood providers and early interventionists, we know too that people from all disciplines, backgrounds, geographies, including family members, may be with us, and we welcome you all here today. As some of you know, we are using the ECHO model, which I will also briefly explain. Courtney, next slide. The ECHO model, I always forget what it stands for. That's why I'm glad it's spelled out for me. It stands for Extension for Community Health Outcomes. It uses a hub and spoke model to connect rural and remote practitioners with specialists who discuss cases that would otherwise be sent to large and distant health systems. The ECHO model was interestingly developed long before most of us knew what Zoom even was. It was originally conceived by a gastroenterologist, Dr. Sanjeev Arora, who realized that people in remote parts of his state were dying unnecessarily because they did not have access to specialized care. So Dr. Arora wanted to share specialized expertise, which is often centered in urban areas and large university hospitals. He wanted to share that knowledge with his state's rural communities by reaching out virtually to fellow providers to build a community of learning. So just know that the ECHO model, everyone is a teacher and everyone is a learner, and ECHO is meant to democratize healthcare knowledge. Next slide, please. There are 4 basic components or principles to the ECHO model. One is the obvious one, we're on Zoom, so the technology to be able to reach people virtually so that we can share scarce resources. We also invite guests who are experts to share best practices to reduce disparities in rural and remote communities. And we also spend time on a case study so that we can learn together and apply our varied expertise in the room with recommendations at the end. And lastly, data is collected to help us monitor the outcomes of our ECHO model and our web-based database. So We will talk more about the evaluation component next, or later, sorry, much later. Just so you know, this ECHO project scope is a series of 8 sessions. Today we are starting part 2, which is focusing on zooming out the bigger picture on addiction and treatment, and our focus is on mothers. Note that we had such a great response for our call of participants that all the remaining sessions are currently full. However, we are planning to offer another round of a similar training series in fall and possibly spring, with the dates to be decided soon. So please keep a lookout for an email of future training sessions, and we ask that you kindly share them with your colleagues and networks across the state. Next slide. Our agenda is, we're underway with the welcome and intros. We also have a guest today whom I will introduce very shortly. And then we'll follow with a case study and the opportunity for us to meet in breakout groups and discuss the situation. And then we'll wrap that up and we'll have closing remarks. So today, Dr. Heather Bell is our expert speaker. Dr. Heather Bell went to the University of Minnesota Duluth, then completed her residency in family medicine at the Sioux Falls Family Medicine Residency Program in 2012. She began her full spectrum family medicine practice and shortly after began to address the opioid epidemic along with her partner, Dr. Kurt Devine. In 2016, they began treating opioid use disorder with buprenorphine. She'll say that better than I could. And Dr. Bell and Devine also have been mentoring providers across the state and students for many years. Most recently, Dr. Bell has become the corporate medical director for MEND, M-E-N-D, Correctional Care and MEND Recovery Services. So thanks, Dr. Bell, for coming today and to speak with us about addiction and treatment for mothers.
Wonderful. I'm just gonna, I just requested access. I don't know if somebody saw that.
Yep, you should be good to go.
Oh, perfect. All right. So yeah, I've been doing ECHO for over 3 years now. So you'd think I had this all down perfectly. Of course, we have a coordinator just like you all have. So I'm going to try to. Okay. Are you seeing the full screen version or are you seeing my thing with the side?
We see full screen.
Perfect. Okay. So if I'm not looking directly at my camera, it's because I have dual screens and my real one's on the side. So okay, so I affectionately just called this Healthy Mom, Healthy Baby because I think that's what it's all about. So prior to joining MEND, I was doing full spectrum family medicine. I have delivered, I don't even, countless babies. Personally, I've delivered 10 babies whose moms were on MAT, some who had been on MAT or Suboxone, i.e. buprenorphine, prior to pregnancy. Some of them I started during pregnancy, even late pregnancy. And none of the babies that I delivered on MAT needed to go to a NICU, needed any type of medication to help with dependence or withdrawal. Even I had a 32-week preemie who was obviously in a NICU, but didn't need morphine or anything to help with withdrawal. Some of what I do is also with grant work, both our ECHO program that we do, as well as mentoring across the state. We, when I say we, I mean Dr. Kurt and I don't even know how many countless babies, at least 3 to 4 dozen babies have been delivered in rural Minnesota, all critical access hospitals with moms on MAT in the last few years since we've been mentoring. Not maybe 1 out of 30 has needed MAT or the babies has needed to be treated for withdrawal. So that's, oh shoot, okay. Can you see my disclosure slide?
No, it says waiting for you to control my screen. So I think you just click through on mine.
Oh, I was sharing. Does that not?
Oh, no, we can't see the share. I'm
Okay,
sharing.
I'll
but
stop
you
my
should-
share.
you
Okay,
should be able. Oh, yeah, perfect.
got it. Sorry.
You're fine.
Okay, so no disclosures, no conflicts of interest. So objectives, we're going to walk through all this biopsychosocial definition of addiction. So I'm going to kind of walk through why addiction, how addiction. One of the biggest things I always hear is this is a choice, blah, 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 all of that. I'm going to explain why that's not the truth. Treatment approaches, so is MAT, medication assisted treatment. Is that just a drug for a drug? Are we just replacing one medication for their drug of choice? Which is definitely a huge thing we hear. And then talk about why this is important and how it encourages healthy moms and healthy pregnancies. I'm going to quickly introduce Casey as my nurse, both in my addiction clinic, my primary care clinic. She coordinates all of our echo stuff and all of that. So if anybody wants any more further information for anything I talk about, my email address is in the chat. Otherwise, chat Casey. Okay, so this is who I am. You already kind of went through that, so I'm going to skip that. So what is addiction? So this is one of my favorite ways of explaining. So here's your brain kind of switch. So you have everything that kind of goes into the brain, your biological, kind of what you're born with, what you have no control over, psychological, social, and then use. So different things around you. These kind of all go into the brain. There's the switch for whatever reason, and then people can become addicted to random or whatever substances. So when you break that down, you look at biology, 40 to 60% of any addiction is felt to be heritable. One example, because it's been studied the longest, is alcohol, is that 7 times increased risk if both of your parents have an alcohol use disorder. So is it exponential? Is it additive? It doesn't really matter. And then if you look at people who have truly diagnosed mental health disorders, whether it's severe major depression, anxiety, bipolar, schizophrenia, a third of them also have a substance use disorder. So this is just something to think about when you're coming to kiddos. It's something to be aware of. Obviously, if, I'm sure all of us have a family member, so potentially that has some type of addiction. But if now you're getting a kiddo into a school and both parents, one's in jail on drug charges, one's, got probation or whatever, that kiddo is at risk of not only because of the environment they live in, but also biologically higher at risk of also developing a use disorder. The psychological aspect is this somebody who's just trying to treat their own mental health diagnosis? Are they numbing their own? Is this their coping? Do they have a physical illness? Are they taking it to kind of cope? One of the best treatments for anxiety out there is an opioid. So it's important to realize that it's not always the other stuff. It can sometimes just be this was the coping mechanism. And if you have a child who's in a situation where they're under a lot of stress or they don't know how to handle things because they don't have the brain development and they don't necessarily have that family support person, this might be where they go. That's what they see their parents doing or people around them doing. And then social, they all kind of play together, of course. Socioeconomic, parental support. I am going to touch on adverse childhood experiences at the end. It's a huge passion of mine. So we are going to kind of talk about that a little bit. And then drug availability. What's around? Saw a guy this morning in clinic and he said he started smoking marijuana at age 8 because his brother gave it to him. And alcohol at 9, meth at 13, heroin at 14, IV at 16, and the kid's currently 19 years old, has been to juvie, has been in and out of foster care, hasn't graduated high school, and is homeless. I mean, what was his chance? It's devastating. And he actually told me he hates meth because that's what ruined his whole family, because his mom got addicted to meth when he was a child. So that's kind of where everything spiraled. So when you kind of get to that brain switch and then addiction ensues, it's important though to understand that when someone has a true use disorder, it is its own disease. So, it is the disease of addiction. It's not the choice. I choose to have addiction. There's something that happens in the brain. And an example of this is we've had patients who, had that random wisdom tooth removed or that random orthopedic surgery when they were a teenager. And just that first pill, we've had the comment multiple times, I felt instantly in love. Like the same description as love at first sight. It was just that first pill, they were done. Like it just hit that switch, factoring all those other things, and they were done. But there's other things that play in here that can help with that relapse prevention. So if someone already has an addiction, how do you keep them on the road to recovery or in long-term recovery? And this is where often there's not enough research and not enough resources on resiliency training, resiliency building, and definitely factors. And that is what we in our clinic, especially our addiction part of the clinic and in corrections, it's just like, how can I say one thing that's going to get into that patient or that inmate or whatever to kind of help give them that hope or that sense of, belonging? My favorite question to ask is, where's your safe place? Who is your person? Who do you call on a bad day? Where do you go? And it's sad when sometimes people are like, I don't have that person. So now we need to come up with something together. And then things that lead to relapse are things like stress, triggers or cues. So you see your dealer's car go by, you automatically start to feel like you're in withdrawal, and now you just relapsed. And then if you're sitting in a house with all your friends shooting meth, I always say a diabetic is only going to look at that chocolate cake so long before they're going to eat it. Shoot, I'm only going to look at the chocolate cake so long before I'm going to eat it. If it's in your face, it's going to get consumed. So I love these slides. They just kind of show, so dopamine in your brain is like your feel good, simplistically your feel good hormone. So when dopamine goes up, we all feel happy. So if you have your favorite mood, you get this little burst of dopamine, and after a while, it kind of levels off. Sex does the same thing, a little bit higher, and then wears off. If you look at, some of the most common drugs, morphine, same thing, different on the dose. Cocaine goes a little bit higher, nicotine a little bit higher, ethanol, alcohol goes up. So this is what happens in the brain with the dopamine. Unfortunately, with addiction, and we'll kind of get to this is what happens. Let's go to cocaine. The first time, and then the second time you use cocaine, it maybe only goes to here. And then the third time it goes to here. And when we're talking like something like an opioid, specifically, it goes from being this positive to, when you don't have it, you're down here, and then you use it and you get back to normal. And then you down here, and then you're in withdrawal, and then use it to get back to normal. And we'll kind of explain that. Now, if you look at something like meth, although is more common than opioids, heroin, fentanyl, it doesn't fortunately cause as much, fatal reaction, but this is what helps. So we already talked about that. Meth increases it over 1,000 times higher than your basal amount of dopamine. The hardest thing about treating somebody with methamphetamine use disorder is they know there is not a thing in the universe they can do that will ever make them feel as good at that very first time they use meth. So even every time they use it, they never get back to that first time, but they're trying. And I asked once in a conference, like, what if you were drinking, had cocaine, and had sex while eating your favorite meal all at the same time? Could that get you there? No, sorry, it's not additive like that. So I was just trying to come up with some type of an equivalent. So when you see people with meth use disorder, it's hard, and we don't have, unfortunately, an MAT to treat that. So like I mentioned, addiction affects the behavioral control areas of the brain. So this is your primitive brain. This is the deep part, the inner part of the brain, the part of the brain we share with every animal species. As humans, we have the frontal lobe. We have this higher executive functioning up in here that doesn't develop until your mid-20s. But this is the part that just says, I need this for safety. I don't need this. I want this because it feels good. When addiction impacts these areas, especially in younger people, it's really hard to develop. Yes, I'm sorry, MAT. I do talk about the acronym a little bit. Some people actually call it MAR, medication-assisted recovery, which I love better. It's just not known as well. But anyway, so when addiction does impact in here, you start doing all these behaviors that we all would think, oh my God, that's crazy. Okay, oh yeah, here it's on this page. So you're using this because it's a reward. So your emotion, your inner reptilian brain goes, oh my gosh, this feels so good. I'm going to do it again. So even though it doesn't seem logical, it isn't logical. The emotion in that inner reptilian brain is going to win. And like I already mentioned, over time, that surge definitely isn't as rewarding. This is my favorite kind of comparison, is this frontal cortex. This is the frontal lobe, our executive functioning. I call it the adulting part of our brains because, it doesn't develop till the mid-20s. The best way to think about this is we've all seen the picture of the mom and dad both passed out with needles in their arm and the 3-year-old in the back seat. You look at that picture and you're like, oh my gosh, who would do that? Like, your kid is right there. These people with these use disorders, they don't have a functioning frontal lobe anymore. All they're thinking is, I don't want to be sick. I'm trying to feel okay. They don't think like an adult. They think like that child, the child that will do whatever around your house. I mean, I have 4 kids, so let me tell you, you just kind of, it's more that child behavior. It just is obviously not worth of a functioning adult. And so people who are using substances, and opioids especially are one of them, they cannot adult. They cannot make adult decisions. They cannot care for anything because their reptilian brain has kind of taken over. Sorry, we love this picture. This is B.F. Skinner. He's who coined the anti-reward. So this is what happens once I was explaining a person will continue to use even though they're no longer getting that reward. Because when they don't have the substance, they're in that withdrawal state. They're in that negative state. So now they're using just to feel normal. This can happen very quickly. Like, I've had more people say, I don't even like fentanyl, heroin. It doesn't do anything for me, but when I don't have it, I am so sick. And we'll have people, for instance, in the jails, people are in withdrawal all the time. We're working on changing that. But people are just like, well, it's just a couple of days of illness. The way opioid withdrawal looks, if you've never seen it in person, like a full several days of it, is the worst influenza meets the worst COVID meets the worst GI flu you've ever had. Like, there is no walking during this type of illness. So it is really bad. You're going to do whatever you can to not feel that way. And unfortunately, as you use, you end up using more. And whether it's that substance or not, it doesn't matter. You're not predisposed to having an opioid addiction. If you have an opioid addiction, you're more at risk of having an alcohol use disorder or a meth use disorder. So it's kind of something to always be aware of. Now, some people who I've been in recovery for 5 years from opioids can drink alcohol socially, and it's no big deal. And when I say socially, I mean like 1 drink a week, if that. So it is possible. It's just something we're definitely watching closer. All right, now we're going to talk about MAT. There's what it means. So now I can just say MAT. Okay, these are the 3 types. I will break them down a little bit more, especially when it comes to moms coming up. So I'm going to kind of transition and talk more specific to women and moms from here on forward. But I want to explain the differences, because I think when people think MAT, we all think methadone. So methadone is what we call a full agonist. So you can see this is the fake methadone, binds to this mu receptor and it fits perfectly. So this binds the exact same way heroin binds, the exact same way fentanyl binds, the exact same way oxycodone and all the other opioids bind. The reason it doesn't create the same high is that it binds, but it doesn't give that surge and it lasts a really long time. So they don't get that big spike, they just kind of level. Whereas heroin binds and you get this big spike and then it wears off. And anything that gives you a big spike right away is where you like it. We're going to jump over here. Naltrexone is the full agonist. So naltrexone is basically long-acting Narcan. We've all heard about naloxone, Narcan. So it completely blocks that receptor. So it doesn't bind into it, but nothing else can bind into it either. A little bit harder to get in society. There's a lot of problems with naltrexone. If you get your shot and a month later, this Vivitrol is the trade name for the once-a-month injectable. A month later, you don't go back and get your next shot, and then you use, the chances of overdose are like almost 100% because you've lost all tolerance. The other issue is if you're on this and you have a major car accident, for instance, there's no pain meds we can give you to help your pain. So you're sedated in an ICU until the pain wears off. Buprenorphine, so this is the trade name for Subutex, aka Suboxone, has the Narcan added. So you can see it kind of binds, but not as perfectly as methadone. So we call this a partial agonist. So it binds there, it binds really tight, but you don't get any type of surge. So there is no ability to continue to use. So if I'm on methadone and I decided to use heroin, I can still get high. If I'm on buprenorphine and I use heroin, this buprenorphine is bound so tightly, I just wasted a bunch of money and I am not getting high from it. So it does kind of prevent that. you can use and use and use buprenorphine and you're not going to get any more out of it. You're not going to overdose on buprenorphine. You can overdose on methadone. So we'll kind of explain how those all relate to moms and pregnancy in a second. Why this is an important topic, why we're all here. This is a little bit older data, but this is fatal opioid overdoses in women, just like everybody else, it definitely goes up. And if you look at deliveries and OUD and hospitalizations, I mean, this is scary. I mean, and this is 2014, so this number has continued to exponentially go up. So moms that are using substances, who are not getting help, who are continuing to use substances, they have a lot of risk. STDs of all kinds, hepatitis C, HIV, even if they're not injecting drugs, they're just smoking drugs, they're just whatever. I will tell you, most women don't actually pay for their drugs. Very few do I ever hear a female tell me, and I've met over 200 people who've used drugs, if not more. Women just don't pay for drugs. They just have a lot of sex or they do a lot of bizarre sexual acts. That's how they get their drugs. So even if they're not using IV, they still have high risk. How they mix their drugs also can spread diseases. These are obviously results of infections, different types of infections getting into your body. Injury, overdose, death, obviously big risks. They can have preterm labor, placental abruption, all sorts of things. Babies, growth restriction, preterm birth, stillbirth. Obviously, the risks of preterm delivery, neurological, physical complications, a lot of baby overdoses, risks of seizures tends to be the biggest thing. A lot of infections can pass through the placenta if mom's having those. And then, of course, the Neonatal Opioid Withdrawal Syndrome. So NAS is Neonatal Abstinence Syndrome. That's anything a baby is withdrawing from, whether that's Prozac or nicotine or opioids. NOWS is when we're talking opioid. It's sad we had to come up with a new acronym for an epidemic, but we did. So why do we do treatment? Why do we not just tell women, nope, you just need to taper off your drugs, quit using drugs, you're pregnant. Of course you want to not use drugs. That doesn't work that way. And I will explain in a minute, but you use it in pregnancy because they don't have the withdrawal symptoms and they don't have cravings. So every time a woman who's, let's say, injecting heroin starts to withdraw, the chance of having a miscarriage or a preterm labor or a placental abruption goes up every time they have withdrawal. So, and that's a lot of stress on the baby as well. So all those stress hormones cross the placenta impact baby's own stress hormones. Decreasing relapse risk if they're in treatment, they're not injecting drugs, they're not around people, or they're not doing as risky behaviors. The number one reason why we treat patients who are pregnant is to get them to come to their prenatal visits. This seems a little bit difficult, but it's often we will meet a person on labor and delivery who maybe had one prenatal visit at 20 weeks when she thought she felt something weird in her tummy and realized she was pregnant, hasn't seen a doctor since. You get them into treatment, they're not afraid to come and see the providers. I don't know if you all are aware of this. I'm sorry, my email keeps dinging. That as of yesterday, they took away the mandated reporting. So as a OB provider, you no longer have to mandatedly report every mom using every substance. I know that's a big question mark to a lot of people. A lot of legislators weren't all on board with that. We had a lot of conversations. Prior to yesterday, we did not, as a providers, need to report alcohol or marijuana. Anything else was reportable. The reasoning is if a patient is worried about getting reported, they are not going to come to the doctor. They're not going to get treatment. They're going to continue to use. That is what their number one thing of afraid is. And then they're afraid you're going to take their baby. Child protection can't get involved if there's actually a child. And that's one of the things we always reassure. Part of the new legislation that went through does still recommend not reporting, but mandated referrals, or not mandated, excuse me. They do recommend referrals. And this is how I always spun it to my own patients is, I am not wanting to connect you with your social services so they can monitor you and torture you and steal your baby once it's born. I want you to talk to them because they can help you with housing, or they can help you with WIC, or they can help you with insurance. They can help you with parenting classes. They can help you with XYZ and ABC all at the same time. If we can do all those things and continue to see me for your pregnancy, continue on your MAT, your baby will be born. You will not have substances on board. Your baby's next screen is no one's going to have substances on board, and you're going to bring your baby home from the hospital with you. Depending on how people have these conversations, this is huge, but mandating reporting went away. So how do we treat people with opioid use disorder in pregnancy? We already talked about MAT, methadone, buprenorphine, alternative MAT, which would be Suboxone, the combo one, naltrexone, and then there's this non-MAT option, which is not recommended by literally anybody, which is when we taper them off of their drug and have them, do abstinence-based treatment. So if you look at the American College of OBGYNs and then SAMHSA, which is like the guru of addiction world, it is recommended to be on some type of MAT. Withdrawal is not recommended because of relapse rates, which leads to worse outcomes. This is pretty straightforward. You should be on methadone or buprenorphine. So we kind of talked about this a little bit already. Methadone is that full agonist. The advantages to methadone, it's been around since 1974. So there's a ton of studies on methadone. We know that it's safe in pregnancy. We know that it's safe in breastfeeding. It reduces cravings, so they're not using other things or cocaine. It lasts a long time. They're good at treatment because methadone clinics, you actually have to go there every day to pick up your methadone. And it reduces all those complications we already talked about. Disadvantages. It takes a really long time to get to a stable dose. During pregnancy, we often have to way increase the dose and split it to take it twice a day, which then can complicate things with the mom having an extra dose at home. And is someone going to try to take that from her? Again, the significant overdose risk because you can use other substances on top of it. They have to go there every day to get their dosing. So sometimes that's seen as a positive and sometimes it's seen as a negative. When you're talking neonatal withdrawal, any type of opioid product, whether it's methadone, buprenorphine, heroin, fentanyl, all the above, there is a little bit of withdrawal that all the babies will have. Methadone is a longer withdrawal. Babies average probably 20 to 21 days, and you're going to have this on your next talk, I believe, 20 to 21 days in the hospital because you're monitoring them for withdrawal. And therefore, most oftentimes will need some type of their own medication to help them through their withdrawal. We want to get them on the right dose. We talked about this. This is the splitting of the dose. Higher dose is better. We kind of just touched on those things already. So buprenorphine, we already talked about that as well. Partial agonist, antagonist, comes in a lot of different varieties. Advantages, there are established safety for both pregnancy and breastfeeding. Lower overdose risk because it won't let that other opioid block. Methadone has a ton of other drug interactions. So a lot of other prescriptions interact with methadone and can cause a lot of issues, including heart issues. Buprenorphine doesn't have that. Office-based, therefore, so methadone can only be dispensed in federally sanctioned opioid treatment programs or opioid treatment clinics. So there aren't a lot around our state, not in greater Minnesota, anyway where I live. Buprenorphine can be prescribed in a primary care clinic anywhere. A provider needs to have something special to add to it, but it's really easy to get. It's really easy to do. So like my OB patients who are in buprenorphine, like I did their OB visits and their Suboxone visits all on the same day. So they have that built-in nice relationship with you. If the baby has withdrawal, it's much less severe and it's much shorter. So if, like I said, I've delivered 10 babies and across our programs, let's say 20 to 30 babies, they average probably 4 to 5 days in the hospital. We do monitor them for 5 days preferably because buprenorphine withdrawal will start right around that 72 to 96 hour mark, just like methadone. But we've not had to treat any. And then there's longer acting formulations. Disadvantages, we don't know really what happens later in life. Like, okay, a mom was on methadone. What happens to that child when they're 3, 4, 5, 6, 7? nobody really knows that with methadone either, but we definitely don't know that with buprenorphine. To get a mom started on buprenorphine, they have to be in a little bit of withdrawal. There's different ways we do this now, so it's not as severe and significant. Not as great if they have a lot of other substances on board, unless they have a good program wrapped around them to help them. The lower treatment retention just comes in because they don't have to go to that place every single day to pick it up, so they're not getting watched as closely. Buprenorphine, because they can bring their meds home, it can be diverted. One thing I want to just say about that is when people sell or share their buprenorphine, so they share their Suboxone, they're not doing it to help somebody get high or get sick. They're they're diverting it so somebody else can get help or not feel sick. And often what we'll find is the friends of the people who get it often will then join our program shortly thereafter because they also don't want to continue using. So it is now considered a second gold standard. So this is the top gold standard for pregnancy treatment. So like I mentioned, Suboxone just adds the naloxone, the Narcan to it. Why is that important? The reason naloxone is added to this was so, like if I melted a Subutex or a buprenorphine, I could inject it and maybe feel a little something because it is still a half opioid, if you will. If I melted a Suboxone film and injected it, I'm going to be very sick because now the Narcan's going to do its job. If I take it normally, Narcan, nothing happens with it. There is no absorption into the body of Narcan. And so it can't be diverted as much. Insurance covers it a little bit better. There's not a ton of data on Suboxone as a combo product in pregnancy. However, if you look at SAMHSA, you look at ACOG, you look at, I have a friend who's a perinatal high risk OB doctor who's also an addiction doctor. We pretty much all leave patients on Suboxone during pregnancy unless they really have a desire to change to the Subutex. So Vivitrol, this is that once a month injection again. Can reduce craving overdoses, can't divert it because you're getting a shot. The problem is there's no safety data whatsoever during pregnancy and afterwards. Like I mentioned, you can't give pain meds. So if there's an unexpected C-section, it can be very challenging. We don't know how safe it is in breastfeeding. Buprenorphine, like methadone, very, very, very little goes into the breast milk. So there's these theories that maybe that's why babies don't have as bad of withdrawal with buprenorphine is because they're getting it traced through the breast milk. Although I've had moms that don't want to breastfeed and their babies are just as fine too. But naltrexone, we don't know how safe it is in pregnancy or breastfeeding, excuse me. So expert panel, they don't want you to do it, basically. If they're on it, you definitely have to consult somebody to kind of help with that. So as far as people, how, getting off of it, why not abstinence-based, which of course then there'd be no withdrawal, there'd be no risk to baby. Typically what is done is, we'll put a person on buprenorphine and then slowly taper them off buprenorphine and then have them not be on anything. The problem is the relapse risk. But obviously there's no long-term complications because there was no medication involved. Disadvantage, relapse rates are up to 90%. People will ask me, how long does a person who's on MAT need to stay on MAT? And my answer always is a person stopping MAT in 5 years, their relapse risk is 86%. So it kind of puts it into perspective how this is a disease. A diabetic getting insulin their pancreas just doesn't get better on its own or ever. So it is a true disease. People aren't very compliant. And there has been neonatal withdrawal documented, which is bizarre, and that's mostly because of people who have still kind of used intermittently. So not recommended in pregnancy. MAT is the best option, only if a person is not accepting or only if a person doesn't have MAT available. That's not usually an issue anymore. So as far as throughout pregnancy, you're going to really want people to come in and be compliant with their visits, which is why MAT is important. Being aware of the state laws and reporting, which of course, like I just mentioned, in Minnesota changed. Discussing pain management for women. A lot of women are super afraid of getting pain meds in the hospital because they don't want to go back down that road. I had a mom that at 28 weeks is when I met her, had been doing IV heroin, IV meth, started her on Suboxone. When the baby was born, that baby's meconium year passed, came back completely clear, even though we didn't really start her on treatment until 28 weeks. But she ended up with basically an emergency C-section. She did not need anything stronger than Tylenol and ibuprofen because we got our anesthesia involved. Our nurse anesthetist, we don't have anesthesiologists in Little Falls. Our nurse anesthetist was able to do some fancy nerve block things, and she never needed anything more than Tylenol and ibuprofen. So it's kind of planning ahead and just being aware of what opioid withdrawal syndrome would look like. I didn't go into any of the scoring stuff because I know you guys have that coming up. You really want to prepare for parenting. So do these people need their own support system? Do they need to go to parenting classes? You know, if somebody was grown up in a house that didn't have any of that, didn't learn that, didn't have it modeled for them, they might definitely need that support even before pregnancy. Lactation consultant during pregnancy, even before they hit lactation. You want to set that mom up for the best possible outcome, like you would for any mom. These moms just need a little bit more support. And then discuss what's the expectation at delivery. We continue the med right through the whole thing. Often an early epidural is helpful. Really afraid of pain because pain means pain meds mean relapse, and they don't want to go there. Manage the expectations. The buprenorphine can help with some of that pain relief as well. So sometimes talking about that. This is the blocks I was telling you about. They're called CAT blocks. Talking to the staff. This was the hardest thing we dealt with when it came to OB care in our facility was our nurses. They were really afraid in a way to have these moms deliver in our tiny little hospital because they didn't know what kind of people would come in with those moms. They were afraid of would they be belligerent like they had used to seeing them in the ER withdrawing? How was it going to go? We had to do a lot of education, very similar to this talk, basically. And we had a couple of deliveries and it went very well. But they're key because that nurse on the labor and delivery floor spends so much time with that mom that if they're at all judgmentals, have any stigma, it can definitely ruin the whole experience. Breastfeeding, little issues with that. Supported unless, hepatitis C, contraindications, the typical infection things. I'm going to skip through that. You really want to talk about post-pregnancy plans. Most pregnancies and people who are using substances are not planned. A lot of these patients are in the 15 to 22 year age group. I've delivered 2 babies in a Native American female between 17 and a half and 19 years old. So it's really kind of talking about, are you wanting kids right away? If you're not, what are we gonna do about that? And then watch their other mental health disorders. Postpartum depression is huge. And when they have coexisting mental health issues, which I kind of already mentioned, you really want to see them sooner. So long-term outcomes, there is no long-term outcomes. Methadone's been around since the 70s, and there's still no consensus on what happens to those kiddos later in life. No real birth defects or no neurodevelopmental impact. The key is how do you differentiate neurodevelopmental impact? If that mom is in treatment, even if she was on buprenorphine or methadone during her pregnancy, but now she has the baby and now she's parenting, that baby neurodevelopmentally is probably going to do better because they have that parenting, they have that resilience, they have that all built in. Whereas the flip side would have been kind of the continuation of the revolving door there. In this one study, toddlers had no more developmental tasks than those from a normative sample. So it's really hard to study because you're not going to do any placebo trials on babies. I really want to talk about ACEs really quickly because this is why focusing on mom care is super duper important. So I'm sure based on looking at where you all work, you all are very, very familiar with ACE scores, adverse childhood experiences, and why this is important to break that cycle. So to remind everybody, ACE scores are broken down into different types of abuse, neglect, and household dysfunction. which results in a lot of different health outcomes. And if you're looking at other uses, they're on the top right there. So how common are they? Super common. 1 in 8 people have 4 or more. You can see more than 2/3, about 2/3 of people have at least one. So these are super common. And so addressing them when kids are younger can definitely help prevent all of this. So greater than 4, risk of alcohol use disorder, risk of suicide. This just scared me. Greater than 5, greater than equal to 5, illicit drug use, addictions, IV use. So if you can't address this at a young age and help build that resiliency, and that resilience, it has to be like one person that's a support or a positive support, a positive influence. That's all it needs to be, and it doesn't have to be a parent. So from SAMHSA, when children are exposed to chronic stressful events, neurodevelopment can be disrupted, child's cognitive function, ability to cope with negative or disruptive emotions impaired, and then they may adapt using these negative coping mechanisms, as we said way at the beginning. So this is the patient I actually was talking to right when I said, I'm going to be like on in a second. This is Ashley. I have permission to talk about this. This is Ashley. Ashley this is baby Jada. Jada is now like 4. This was my first baby I ever delivered with mom on MAT. Dad is on MAT. Older sister was 10. She's probably 12 or 13 now. She parented that older daughter while using substances. She will tell you that is her biggest stressor today, both because they have difficulty bonding, and the other daughter has a lot of resentment. Like, how come you're a better mom to her, and now there's another baby in the picture, than you were to me? And so with this is baby Jada. Baby Jada didn't need any medications, no child protection. We actually did. Ashley agreed to let us, like, if you will, report her. We talked to the county, and she was able to get a little bit more services than she had before that she didn't know she was eligible for. And then we did due diligence when she came into the hospital in labor. We called the county and just said, hey, just so you know, Ashley's here. We got releases, of course. And they said, that's great. We're not worried. Signed off on her case. So if you kind of get them involved right away, you can have super awesome outcomes. I just love this picture. So yeah, that's what I got for you today. Like I said, my email's in the chat. Otherwise, Katie kind of coordinates our ECHO. Casey's our RN care coordinator, so can get all sorts of information. We actually have a lot of handouts that we give people during pregnancy. We have them at the hospital to talk about what is addiction, what does neonatal withdrawal syndrome look like. So then they're anticipating it. They know about it ahead of time. You can tell moms what to look for, or whoever is going to parent. It could be a grandparent or foster care, kind of things for them to watch for. So yeah, are there questions? I went through that fast. I'm sorry. I wanted you guys to be able to get to your case.
Yeah, thank you so much, Dr. Bell. That was very informative, a great overview of addiction and treatment for mothers. A lot of myths dispelled today by you. Thank you for that. Thank you for being a family-centered physician and for helping to destigmatize addiction and sharing your expertise with us today. So thank you so much. If anyone has any questions for Dr. Bell, you could put them in chat, or you could reach out to her via the emails she shared today. I think we'll switch over to the case study now. Does that sound good, everybody?
It's Rebecca. I have one question for Dr. Bell.
Okay.
It's a quick one. Dr. Bell, thank you so much. That was a wonderful presentation, so informative. And again, we appreciate your family-centered focus. We have primarily early intervention providers, and I'm going to ask a similar question I asked last week. Just one piece of advice would you give early intervention providers in working with families that you've learned?
Yeah, and whether it's early intervention with early childhood or late, the question, the answer to that is really just being welcoming. So like, ask the questions, not being afraid to ask the questions. I sit in a jail, I'm like, well, What kind of drugs do you like to use? You know, I have a rapport. I've been doing this for years, so I know how to ask the questions a little bit more comfortably than some, but just really understanding what makes them happy, what makes them feel comfortable. Find that in to connect with the people, even, you know, you don't have to go personal with them, but just find a way to connect. They will open up and tell you everything. And then everything else falls into place. You know, you find one connection, every other avenue you're going to need will present itself to you, because they will just literally tell you exactly what they need once you've connected. You know, it's people who have a hard time or they're too methodical, like doing check boxes on a sheet of paper because that's what they have to do to fulfill some type of weird requirement. Talking to them, asking the questions in a calm, comfortable way, you'll be surprised at how amazing those moments can be. And they are literally, we always say when we do an induction on people, so we say it's an induction is when you start somebody on their Suboxone, those people imprint on you like a baby duck, because you literally saw them at their very worst and then they walked out of there feeling 100% better, and they will trust you and follow you and stalk you to the end of the world because you are their favorite human. So, and that can be for anybody. And I think you all are in a great position because you have the whole family there. And of course, I'm very family centered, but you have the whole family there and can really do a lot of, I'm sorry, I like to talk in tangents, but you can do a lot of education on that, because sometimes you'll have one of the parents has a use disorder and the other parent just doesn't get it. They're like, don't use. And this creates an animosity. So really trying to be that safe place for everyone, to open that comfortable communication for everyone, which is the best of the whole family unit.
Thank you so much.
Of
Yeah,
course.
thanks, Dr. Bell. I appreciate you coming today. Thank you so much.
Sure.
Um,
There's a question I can touch on really quickly. So
okay, sure.
the mandated reporting of parent using substance. Now, I have not read the legislation personally, but my addiction friend, high risk OB doctor, sent the email. So they do not need to be reported. So if you have a mom come in, or you know, and I don't know how it is for you all, I would wait till your governing bodies reach out and say, as an early, you don't have to report. Like, I'm a mandated reporter. We're all mandated reporters, but as a provider with a mom coming in, you find out she's using, I don't have to report her. Now, I won't know. I don't know specifically your recommendations if you find out there's a family member using with kiddos there. So I wouldn't change anything you're doing until your head powers kind of explain that or come down to you. But I just wanted you to be aware that if that happens. Nope. And to answer that question, only if you see it or they admit it. Nope. If I ask, if I do a urine drug screen, which is a horrible screening tool, if you in any way, shape, or form find out they're using, whether they tell you or you find out, you still don't have to report that. Again, it's still a recommended referral, though.
Thank you, Dr. Bell. And
Of
maybe
course.
we can look at that new legislation, provide a link out to everybody to look at. Thank you. Thank you for your advice on that, waiting for them to find out
Yes.
from their governing bodies. So thank you so much.
Of course. Thank you so much for having me.
Great. It's great to have you. Okay, everybody, I'd like to now move us to introduce the case study part of the day. Our case study presenter today is Dr. Jessica Simasek. Dr. Simasek developed and now manages the Institute on Community Integration's telehealth laboratory, and she is the director of the ICI-led telehealth or teleoutreach center at the brand new Masonic Institute for the Developing Brain at the University of Minnesota. Her expertise in early intervention is based on supporting children with neurodevelopmental disabilities, and she focuses on complex communication needs and the use of telehealth as a delivery mechanism. So Dr. Simasek, thanks for coming today to run the case study.
Thank you so much. It's nice to see everybody. If I saw you last time, welcome back. We will follow a similar structure. If you weren't here, you want a little refresh, I'll just briefly walk you through how the case study is going to work. I'm assuming everyone is hearing and seeing me, okay? All right, perfect. I always like to check. So we go through the case study as you've seen on your agenda, and we talk about some background information and strengths of this particular case. And this is a great way to share knowledge as a community, because all of you are bringing knowledge to this experience that helps each other, and then to also build in from the didactic presentation that we just had and kind of apply that knowledge that we've all just collectively learned together. So after we walk through the case study, there'll be some time where you can ask some clarifying questions if you need a little bit more background information, which I may or may not have, but I'll try to answer to the best of my ability. And then you'll have time to go into breakout groups where we have some guiding questions for you to reflect on and provide information about. And then we'll come back as a full group and share out what we collectively discussed. And we'll use that to form at least 3 primary recommendations that you would have for this particular family, or for a family that you might encounter who's in a similar situation. All right, so we'll get started here. Next slide, thank you. So this week, we really wanted to focus on, which all of us as early intervention providers already value, but very family-centered early intervention. So I'm going to give you this background information, and this is kind of, again, through the eyes of a child, but know that that child is being supported by her mother and their family, and keep that lens as you're providing recommendations, not just how to support this child, but how to support the mother and the family unit. So this is a child who's 3 years old, 3 months old, and lives with her mother and a non-biological sister, and does attend preschool 3 days a week in a Head Start program. And kind of the topic areas we're going to touch on is, again, supporting a parent in a family-centered way. This parent is in recovery, but is also experiencing some additional stressors currently. And also all of the families we're supporting, we just assume that they love their children very much. So we will also make that assumption. The child was affected by Neonatal Abstinence Syndrome, and there are some child developmental concerns. Okay, next slide. So this is just a little bit more detailed background information, and I kind of touched on some of these pieces, but I'll just briefly touch on them again. We are supporting this child and within their family. They have a parent who is in recovery. The child and the family have some additional stressors going on. They recently moved. There was a change in employment status for the parent. The parent is a single parent and has found out that she is unexpectedly pregnant. The family lives in the Twin Cities metro, and they use public transportation. The child attends a split week Head Start program, 3 split days a week. But this is a new setting since they recently moved. So the child's relatively new to this program. There's been some behavioral concerns or developmental concerns around the child engaging in some tantrums and kind of chewing or eating non-edible items. The parent has been referred to PCIT, parent-child interaction therapy. Okay, we try not to use acronyms in here because it trips all of us up. So they have been referred to the service but have not started engaging in it yet. The child also receives speech language pathology services 2 times a week for a total of an hour. Sleep is a difficult area for this child, and so therefore the child and the parent are not getting enough sleep each night. Okay, next slide. We always like to start with strengths. Strengths are very important. We're supporting children and families. So the child is a very engaged child, very happy to be around people, loves her family very much, does have developmentally appropriate language, and they haven't tested it, but likely cognition. Thanks, Adele. And then there's strong support from an extended family. So the parent has a network of her extended family around her who help to support her needs and the children's needs. They're financially stable, and the child's able to attend some in-person preschool. Now they want to engage in the parent-child interaction therapy, but the transportation issues are a little difficult. And a lot of those therapy options are a good distance away from them. And like I already stated, the mother is unexpectedly pregnant and is not feeling very well from that pregnancy. And they've also recently moved and have some other stressors going on. All right, next slide. Some of the interventions or actions that have been tried and kind of the gauge of how successful those have been is the parent has been coached on providing praise to the child when she's engaging in appropriate behavior and to reduce a lot of verbal attention around the tantrum. So just not to give them a whole lot of energy. The mom does really well with this and the child's really getting there on learning these skills. They've been provided with some visual schedules, which are successful, but need to be very detailed and specific. Helping the child wait and do turn taking are some of the skills that they'd like to keep working on. There's been a little bit more success with the turn taking. Waiting can still be a little bit hard, like it is for many 3-year-olds. They need to, or they'd like to engage in the parent-child interaction therapy, but again, there are some difficulties with getting that set up and getting there. It's been recommended that they use Chulery to kind of replace a pacifier and hopefully help address kind of the chewing on or eating of non-edible items. Melatonin was not reported to be successful to help with sleep for the child. And the other medication that was tried, Tenex, reportedly knocked the child out, so also was unsuccessful. All right, next slide. Some common kind of stressors or factors that might be good to keep in mind as you're reviewing options and recommendations for this family is that sleep is poor, which of course, for any of us who are parents know that can make it really hard to function during the day. The mother's reporting the child wakes up or stirs, up to 20 times per night. The mother hasn't been feeling great and has been tired and might need to kind of rest more and have lower energy. And this can kind of create more difficulty for the child. The mother is very loving and is able to implement kind of focused and short intervention strategies or interventions. But she does have another child in the home and doesn't have a ton of energy or time to be taking the child to a whole bunch of appointments. And so any recommendations should keep that in mind, just this mom's capacity to do all of these things and that she needs some support. All right, next slide. These are some of the guiding questions we'd like you to take into your breakout rooms. Of course, if your conversations take you elsewhere, that's okay. We want to learn from each other. But when you come to report back from your breakout room, it would be great if you could type in the chat some recommendations or considerations around these 3 specific questions, which I'll read to us in a moment. And also, if you're in the area, feel free to make these really specific, that these are some, that instead of maybe just she should look into this, parent-child interaction therapy, maybe some of the places where they could go to a website where they could go to find, the closest provider to them or something like that. So feel free to provide really specific information too. So what would you recommend to the family regarding, kind of that prioritizing of interventions? This parent can't go out and do all of these things tomorrow. So where should she start? What would be some good places to prioritize to really help support them and to help deal with any transportation issues and just kind of minimize the need for a lot of complicated transportation? And then how can a family-centered early intervention process support this mother? She loves her children very much. She wants to do everything she can to support this child, but also, of course, is under some additional stressors right now. And then what any other supports or strategies that could be tried? So before we go to breakout groups, I will pause and see if anybody has any clarifying questions that they'd like to ask. Courtney, should I give everyone another minute to come back? Okay. if you want to get started, I was able to join a group, and there was a really great discussion going on. So, and last time we did our last scope, we had so many recommendations, we couldn't even read them all. And that was what I'm going to call a good problem to have. So if you want to get started putting your recommendations in the chat, that will give us, we'll get them all there, and then we'll start the summarizing process. And I'm also keeping an eye on the time. Courtney, am I okay on time to, okay, great. Well, it looks like they're already rolling in. So let's go ahead and take a look. All right, so we have group 5 reporting out. For the first question, cab vouchers or, MA might be able to cover some of the transportation, which I think is great. Metro Transit, reduced cost programs, and then having some, could there be some in-home parent-child interaction therapy? So kind of reducing their travel to another clinic, having those providers kind of come into the home or over telehealth. I think that's a great recommendation. And then for kind of that second point of family-centered intervention to support the mother as she's supporting her child, tapping into that extended family network. Could someone come watch a child, the kids for an hour or two, or help with some specific routines? I think that's a great strategy, especially if mom needs to rest a little bit extra right now. Or when, she has a newborn at home too. And then also looking into their other medical diagnoses, and choices assessment see if they qualify for a PCA or other services, and then the MA multiple forms. So thank you, those are great. And some similarities and differences from the group I was in. All right, so group 4, and I'll probably, since we have so many rolling in, start the summarizing process soon here, and you can read them all specifically yourself. But this group has really highlighted sleep in all capital letters, and that did come up in our group too, but I won't steal the getting to go through our group. So, but yeah, sleep is a big deal here, right? So we all know that when we're not getting enough sleep, it's really hard to function during the day, and it's really hard to have energy, and that's hard for both the child and the parent and the other child at the home. So that if we're prioritizing interventions, sleep would be one to really make sure we're kind of tackling first. Yeah, so the child does have developmentally appropriate communication skills. So why is the child in a private speech language pathology? I don't have the full background on that, but I think the question is a good one, that if that's no longer necessary, maybe there was concerns about a delay and those are now resolved, that could be something to either discontinue or do a push-in, where a speech language pathologist could visit the Head Start or home or some kind of remote option. So I think that's a great, that we're always reassessing, right? So just because that was the services that made sense at one point, it doesn't mean indefinitely those are the same services. And then virtual options, but there might be pragmatic considerations. So does this family have access to devices or internet accessibility to do those virtual options? And I know sometimes we recommend to families that sometimes districts or libraries are starting to do this. We'll have like a hotspot you can rent out or use for a while, or a tablet. So making sure they had the kind of technology to connect. All right, so another group has brought up sleep. So I think we're kind of starting to summarize that sleep is pretty key here, and that there's probably some recommendations just around a sleep hygiene routine. I'm gonna go scroll down a little bit because sleep, I think, is popping up in all of these. Looking into a sleep coach, or again, more of like routine or hygiene, making sure there's some check-in with primary care or with the child's pediatrician. Is there some underlying reason that sleep is so difficult right now? See if sleep comes up again. I do know in my group too, we talked a little bit about, it's related to sleep, that it's the child is just in 3 days a week of split day Head Start, could they qualify for some childcare, or could they extend out to do more days? And that might help with both sides of the issue. One side, the child might have more of a routine that encourages that sleep at the appropriate times. And on the other side, it gives mom a chance to kind of sleep or rest if she needs to catch up a little bit from the night before. So I thought that could be maybe our recommendation one is we need to investigate ways to improve sleep. Some of that will be recommendations to the family, but some of that could be pushing in with services that get the child in a little bit more of a routine. And of course, kind of getting that check-in with the doctor to make sure there's not a medical issue. Okay, so I think that one's good. It looks like there's a second place where like respite care or PCA type services have popped up, crisis nursery. So I think that might be, those have come, I see that in maybe 3 of the different groups that have reported out here. So just making sure that this family is being kind of assessed for everything they could qualify for, to make sure, and I guess we could probably also include the extended family in that bucket. If we look at number 2, is there some service, some supports or external services or family members who could push in to help make sure mom is getting some time to rest and do other things she needs to do so that she's really, able to be the best parent she can be, and with enough rest and sleep. So I think, related to sleep, but also just related to making sure mom is getting some care in, as well as looking into respite, PCA, or, and/or extended family member to kind of step in once in a while, at some regular time to help support. Oh, and it looks like we're just about to wrap up. So I think there's 2 groups that have kind of brought up some of the different therapy components. And I think looking at, remote options or in-home options, so they're not having to go and do a bunch of transportation, would probably be our third summarized recommendation. Is, could we prioritize what does need to be at like a clinic type location? And if it doesn't, let's try to do it at the home or over some remote virtual way, or at the Head Start, so that we're reducing the amount of transportation complexity for this family. So I think that would probably be our 3. Feel free to speak up if you think I missummarized those. And then Courtney does help us summarize these and send them out to you, so that we can all, gain from that knowledge. So I don't want to take us over. Thanks so much, everybody. And I will turn it back over to Rebecca.
Okay, thank you, Dr. Simasek, for your summary. And again, we'll fine tune that based on whatever you put in chat. So please put some more comments in chat if you, for example, if you want to highlight the feeding challenges or something like that we didn't cover as much. So thanks, Dr. Simasek, and thanks to everyone for actively participating in our case discussion today. As Jessica said, we will provide a summary by email to all attendees on the 3 top recommendations in a few days' time. So also, thanks again to our subject expert, Dr. Heather Bell, for sharing her expertise with us today, and to Jessica for her facilitation. Part of ECHO, as you know, is to constantly document its effectiveness for you as learners and for our learning community. So you will receive an email from, what is it, Courtney? Could you remind me? Is it?
I believe it comes from like UMN Project Scope.
Yeah, that's what you told me. Yes, so you should expect an email with a link to a red cap survey from the UMN Project Scope. Please fill it out as soon as you can while it's still fresh in your mind. This feedback is used to improve how we run our ECHO, and it also can help us shape future sessions. As we mentioned, we might have in fall and spring as well. And also, I saw in chat people are interested in the certificates of participation. Those will be sent out within 2 to 3 weeks after your completion of the feedback survey. We're buying ourselves a little wiggle time over the 8 sessions just because this is our first echo, and so we want to make sure we do it right. So we're buying some window of time to send out those certificates, and thanks for your patience on that. So next up, we have on Tuesday, June 1st from 3 to 4:30, we will speak specifically about NAS and NOWS. Our guest will be Dr. Fran Precker. Again, it is full, so we may see some of you, we may see new faces, but again, we'll try to have future sessions so you can get the information. And that is it. Thank you so much for participating today in session 2 with the Minnesota Project Scope Echo. We hope that you're learning from us as much as we're learning from you. I appreciate getting to know you a little bit better in the breakouts. It's always good to see familiar faces. I did have one repeat person in my breakout. So that was good. All right, you all, take care and thanks so much.